what I'm going to do today is to set some of the context about health technologies and their evolution, the context in which they're used, the way that AI is changing the shape of things, and think about AI specifically around, both the vision of the kind of utopian vision of how wonderful it could all be if AI is pervading healthcare technologies, but also the dystopian view of, what are the dangers, what are the pitfalls of employing and relying on AI widely in healthcare. And I'll draw on some of my own work to illustrate some of the issues with those different kind of perspectives. I'll draw particularly on one example that's from ophthalmology, and then we'll close by looking to the future and hopefully asking some provocative questions or having interesting discussions then. So we've had innovations in healthcare over millennia. My illustrative diagrams here show on the left, I don't know, can you see my mouse? I'll assume so. There's just a generic plant. Last year I was fortunate to give a talk in Salerno in Italy, and they have a whole museum/garden of medicinal plants. They had hundreds of them there for different kinds of health experiences, different health conditions. And, they're changing over time, or they're being synthesized and used in different ways. But we've had plants and related products for thousands of years now. The picture in the middle is a rather scary surgical knife. It's in the Wellcome collection. Fortunately, no longer being used in surgery, obviously, but it dates from Roman times. So it's, again, nearly 2,000 years old, heading that way. Illustrating how long we've had physical objects to support health interventions in healthcare more broadly. And the diagram on the right is the first of several that you will see that's taken from one of our studies on the introduction of artificial intelligence, specifically in ophthalmology. I won't explain it all at this point. I will explain the different components of the diagram later, but suffice to say that it's taking physical information and digitizing it, analyzing it in terms of AI, and coming up with recommendations for future treatment and management of health conditions in that context. So we're seeing, and the digital is becoming much more prominent and much more prevalent. Not that the others are disappearing, it's just becoming a bigger field of possible interventions in this space. So these new technologies that we now have access to, and also changing expectations of, the quality of life that people expect, the quality of healthcare, the kinds of interventions that are available, they're all creating lots of new opportunities in this space. So, we're seeing more kind of telehealth, new models of shared care, data being transferred from one country to another. I think I heard a news broadcast a day or two ago that described as a surgery that had taken place where the surgeon was several thousand miles away from the patient. I should probably have paid more attention to that news item than I did. But, it's just an extreme example, a newsworthy example of telehealth. The data networks and the way that different devices are communicating now support new kinds of data integration and hence new kinds of synthesis and analysis of that data, which in turn offer potential for new understanding, particularly not just looking at health data, but also social data and climate data, because all of our health is directly or indirectly affected by our wealth and by the environment in which we're living. And AI is at the heart of a lot of this, not all of it, but quite a lot of it. And it's supporting new styles of reasoning, new styles of interacting that allow us to do new things in this space. And of course, as part of that, incidentally, miniaturization is making more products feasible, more products affordable, allowing yet more data to be gathered, for analysis in various forms, and bringing healthcare perhaps closer to individuals who are managing their own health. And along with that, we have this changing culture. The phrase "no decision about me without me" was introduced, I think, probably 15 years ago or thereabouts in the UK as part of the National Health Service strategy, that individuals should be involved in and hence understand enough about their health conditions to be able to be part of that decision making. And so we see a greater focus on shared care and increasingly a greater focus also on people managing many aspects of their own health their own way now. But just to note that there's also what's often called a valley of death. That's not death in the health sense of that word, fortunately, but that sense that a lot of products don't make it from early innovation and conception actually into valuable products that are hitting the market and having an impact on real health technologies and real healthcare. Elwood et al. Identified 5 particular challenges in this space around clinical validation, the need for clinicians, and through clinicians also patients, to trust the technologies that are being used, to have confidence that they are, that the clinical decision from the AI is actually an appropriate or optimal decision, etc. For example, we need to think about the risk assessment of not just AI, but all health technologies, not just the digital, but also the physical aspects of them. We need to understand how the technology will be used, not just this abstract idea about, oh, this technology would be great, let's all use it, but actually what are real people doing in their real jobs and their real lives to actually make that technology fit? Or how much adaptation do people need to do to make it fit and be usable? It needs to be valuable, of course, because some of these technologies are very, very expensive. Do they actually demonstrate value to the users? Are they worth investing in? And also, identifying champions for diffusion of innovation. Every new technology needs advocacy because people are generally much more comfortable sticking with what they know. And, downstairs, I am in my loft presenting this talk in my study, but downstairs on the fridge, we have a magnet which says, if the user can't use it, it doesn't work. I.e., however wonderful your technology might be, if it's not actually usable by and useful to the human beings who are intended to be using it or impacted by it, then in some sense, it doesn't work. To me, it's surprising quite how long we've had AI in healthcare. Of course, the thing that's called AI, the kind of technology, the kind of computation underpinning the word AI, has changed a lot from the 1970s to the present day. But even back in the 1970s, we had expert systems such as MySyn, which were aimed to replicate clinicians' reasoning and diagnosis with the idea that they could support clinical reasoning or perhaps even take some of it over. We haven't heard about that kind of product for many years now. There were more recent developments along broadly the same kind of lines with decision support systems such as Open Clinical, which again, I don't think we hear about in the modern day and age. More recently, within more of your living memories, I suspect, we've had tools like DeepMind and Babylon Health, and you can probably name many, many others, which did exploit the computational power of accessing large data sets and doing big chunky analysis on them. Some of those tools have continued. A lot of them have been quite controversial. Some of them have since disappeared. And now, in this decade, we're seeing that AI is becoming pervasive in the underpinning technologies. At one time, it was difficult to go off grid. One time it was possible to go off grid. Then it became increasingly hard to go off grid. It's now becoming increasingly hard not to be using AI in any of our digital interactions. We're often not even aware of it. But it's a much slower journey for technologies that explicitly state that they are medical to reach the marketplace because of the hurdles of regulatory approval and related reluctance from clinicians, particularly, but to a lesser extent, patients, towards using these kinds of technologies. Examples of AI technologies that are showing some kind of impact in this space are pattern matching, particularly image recognition and differentiation between healthy images of healthy health people and images where people have some visible health condition. Chatbots are again becoming increasingly pervasive in this space, and the ability to synthesize data in multiple modalities, not just text and numbers, but images and auditory information, all together to enable us to make new kinds of decisions in this space. So, AI has really changed a lot over the last, however many years that is, quite a lot now, isn't it? 50 plus. But we've also have different contexts and different kinds of users. And I'm just illustrating this with, a kind of spectrum from clinical care where the clinicians are inevitably in charge. The photo I've included in the little circle here is of an anesthesia machine. By definition, at this precise point, the patient is not conscious. They're not involved in the decision making at this, they may have been earlier, but they're certainly not during the operation. Shared care is, sorry, I've chosen pictures that happen to include tubes because they're more kind of evocative than pictures of screens, basically. Shared care, this picture is from a shared care dialysis centre where patients go and have their dialysis under the supervision and with the help of nursing staff in that context. The third picture also happens to be dialysis, just because I have quite a few dialysis pictures. And this is of somebody dialysing at home. There are healthcare professionals available, but they're not in this individual's house. They're at the end of a phone line. He, in this case, it happens to be a man, is managing his own care, having had quite a lot of training on how to do that. All of these are digitally controlled technologies. And for self-management, I've just taken a picture from the version of Couch to 5K that I happened to be using a while ago, which is, of course, not so much about a health condition, but about well-being. So our utopian vision, if you like, sorry about the picture, most of the other pictures of utopia were even worse. People are, this vision is that people are actively involved in monitoring their vital signs, self-managing health, self-managing their well-being, supported by self-tracking, by behavior change technologies, by recognizing that new styles of analysis can help us to gain new insights into our personal information. The utopian vision also includes doctors being able to respond more rapidly and reliably, enabling them to focus more on real care due to the improved efficiencies within the system. And, they can also be alerted and intervene as needed, confident that what they've got is reliable information. And that's about the individuals, but we also see the kind of population health outcomes from some of this. The individual's data can be quality checked, pseudonymized, aggregated to support population health level research, to understand better about the impacts of different interventions on different health conditions, on the life course, on how one condition can influence other conditions, etc. There's many different kinds of insights that we need to actually improve the quality of healthcare. On the other side, we have a dystopian vision where perhaps where the AI becomes the master rather than the assistant. So Kamran Abbasi talks about the reverse centaur vision, where clinicians become the overseers of the technology, responsible for how it works, and taking responsibility, but without having the capacity to evaluate every decision that's made by the AI. Giving them an oversight that makes them efficient or makes the process efficient, but doesn't actually give clinicians autonomy or the ability to feel that they are really caring for patients. Data can be shared without fully understanding the safety implications for patients, the consequences of inappropriate AI decisions, because they may not have taken all the right information, or they may not have been trained accurately or thoroughly enough. And data sharing is challenging our established views of privacy and of data security in many, many ways. And people may be required to use technology regardless of their digital or their health literacy, which can make many people feel disempowered, make people feel vulnerable, make them feel unsupported in the clinical context. So those are two, if you like, very contrasting visions. You may or may not agree with either of them. You may have other views of dystopia or utopia in this context. I'm now going to move on to talk about a case study, just one of the projects that I've been involved in. I wasn't involved right at the beginning of the work, which was back at least more than a decade ago, but have been involved for the last several years now. And this particular project is studying ophthalmology. Probably most of you have had some experience of going to see what we colloquially refer to as an optician or an optometrist. We go to primary care. We have various kinds of eye tests of the kind illustrated by the pictures on the right, none of which are my pictures. They're all open source ones. So there are many measurements and tests. Increasingly, people are being offered scans such as OCT, otherwise known as optical coherence tomography, and fundus images, i.e. photos of the back of our eyes. And primary care is responsible for two things, principally. One is the decision to prescribe glasses or contact lenses, and slightly tongue-in-cheek, I note that glasses are an early form of wearable technology, though not as exciting as some of the more recent ones. But also critically, optometrists are responsible for decisions to refer people to secondary care, i.e. to hospital care, or to monitor people for eye conditions that are beyond just failing vision, but into various other kinds of clinical conditions. So as part of OCT in particular, the scans have been resulting in many false positive referrals to secondary care. There's the picture at the bottom on the right here is a fundus image and also a coloured scan, OCT scan image. Most of them appear in black and white originally rather than colour. And the picture at the top is an early press release from Moorfields Hospital about some of their successes in developing an AI algorithm for detecting various retinal health conditions. So in their case, the AI decision support makes recommendations for both the diagnosis of a health condition and referral to further care from primary care into secondary care. The original reliability of the AI system was tested through a retrospective clinical trial where existing scans where the outcome was known for the patient were reanalyzed using the AI algorithm, and the outcome from the AI was compared against the outcome from the ground truth, which was the clinician's assessment. So when I joined the project, we had this baseline of an AI system that had been clinically proven in a retrospective trial. And what we were being asked to do was to understand more about the human engagement with that. How might the introduction of this kind of technology change the workflow between primary and secondary care, the workflow within primary care, the experiences of people in both contexts with different roles, and also how does making the display of information affect clinical decision making? Excuse me a second. So that algorithm, which is described in the paper that I cite at the bottom here, starts with an OCT scan. This is a more typical grayscale OCT scan here. And it comprises two algorithms. I'm not going into the details of how they work because I don't understand them. But the first one produced what they call a segmentation map, basically a map of the eye. The yellow bits are not part of the eye structure. The variously color-coded parts in the middle are part of that structure. And then the second algorithm delivered two things. It delivered a diagnosis probability, where for each diagnosis, there was the probability of whether that particular diagnosis exists. So it's not about them adding up to 100%. They don't. You know, there's a 40% of CNV, a 99% of chance of drusen, etc. I'm not an ophthalmologist. Don't ask me to explain them in detail. But then the referral suggestions about whether this should be referred to hospital urgently, not urgently, or not at all, those do add up to 100% because it is assessing the probability of each of these being the appropriate referral suggestion. So as part of our project, the statisticians in the team ran a prospective clinical trial, which involved 4 hospitals, 26 primary care sites linked to those 4 hospitals. 13 were put into a control group where it was basically business as usual, but included sending the OCT scans to the hospital. And 13 were in the intervention group, where the decision about whether to refer was not made by the primary care physician, by the optometrist, but by the ophthalmologist. So not in primary care, but in secondary care. And in parallel, there was a kind of shadowing of AI decision making to compare with both the optometrist and the ophthalmologist decisions. And what was found in that comparison between the AI and the human decision making was that actually a significant proportion of the cases couldn't be analysed because the optometry practices, the opticians, the high street opticians had a different kind of OCT scanners, which didn't produce scans of the quality or the particular form that the AI algorithm needed to work. Where data did originate from the same devices as the training data that had been used earlier for the retrospective trial, the performance was better than optometrists. But where it did not come from those same devices, the performance was quite variable. This is again published. You can view it at the bottom. So our questions were, how do optometrists make the diagnosis decision about retinal disease with and without the AI and with and without the explanation? And what factors influence their trust in the system? So this is one study that Josie Carmichael, my PhD student, did, which was a controlled experiment where she had 30 participants who were all qualified optometrists. And each of them was asked to assess 30 cases, 10 in each of 3 conditions. In one of them, they just got the fundus image and the original scan. So the bits on the left here, where, as I said, the fundus image is the photograph and the original scan. It's actually typically like 128 slices through, photographs through the eye that each take a slice, of which the focus is usually on the deepest ones, the ones closest to the back the eye, to the middle of the eye. Some of them were given those, plus the AI output, the diagnosis and the referral suggestion, which I have already explained. And the third lot were given the original scan and the segmentation map, where here now you see the coding of each of the areas. But again, you know, it's not the point of today to go through those. So we compared the decisions that were made in each of these three different situations. So overall, 74% of the people's responses were correct as compared with the ground truth of the clinician's assessment of it. When people did it manually, these three bar charts are the manual, the AI diagnosis, and the AI diagnosis plus segmentation, i.e. the information that was presented to people. And you can see that actually the participant was correct more often when they were unsupported by the AI than when they were supported by the AI. And even the difference is even more stark when they're given the segmentation map as well. And this surprised us. You know, this was not what we were expecting at all until we looked really deeply into the case studies that we had provided, which had been carefully balanced so that people had very similar case studies in all three conditions, but obviously they were looking at 30 different scans. So when we looked in detail, the differences often came in particular kinds of scans. And this one, you may or may not be able to see it online, but there is a very thin blue line above the larger green area, which is what's called epiretinal membrane. And it appears here, but people who didn't see the AI segmentation map may well not have noticed that very thin layer. And indeed, that very thin layer is not clinically significant. So the algorithm has been trained not to highlight this thin ERM layer because it's not clinically significant. But when people saw the segmentation map, some of them actually gave the view that it was clinically significant and therefore should be referred. And of course, there are also clinically ambiguous cases where different healthcare professionals might give different responses to the same information set. So, you know, the impact of the technology on people's performance is quite important in this context. And the real world significance of the data needs to be interpreted and act on by people. What I mean is, you know, we're going from a clinical phenomenon, it's being measured, it's being analysed, and then the data information is being presented back to the user. So it matters what you measure. In this case, the AI was only working from the OCT scan. It was not working from other information, such as people's age, sex, or clinical history. And people, you know, the clinicians wanted to know a lot more about their patients. It matters how the data is processed, you know, that whether it's, you know, how well the data matches the algorithm, how well people can trust the algorithm, when they should question the algorithm and, you know, perhaps look more deeply into it. It also matters how information is presented, and that was really, you know, that example I've just given was an example where the information was presented back to people in a way that kind of changed their interpretation of what they were seeing on the OCT scan. In a second study, Josie conducted some interviews, principally in primary care. And what she interviewed, I think it was 19 or 20 people who were all practicing optometrists. And what she found was that people's prior training and experience are central to their adoption and effective use of these technologies. So in particular, in this case, OCT scans have become widespread and were included in the undergraduate training program in about the last 8 or 9 years now. And so people who have graduated when they were trained as part of their initial training on OCT scans were much more comfortable with the technology than people who have had to learn that as part of their continuing professional development. And, you know, some of those are really enthusiastic about technology and others are much more reticent about it. So people's training and their prior experience are absolutely central to adoption of new technologies, whether that's the scans themselves, the idea of teleophthalmology, or the idea of AI in this context. People really, in the interviews, people really valued the segmentation maps. It helped them to resolve uncertainty about perhaps some ambiguous data on a grayscale scan. But confidence was reduced when sometimes the segmentation map didn't show everything that looked clinically significant. And this pair of images at the bottom here is an example of that. We've circled in red a strange area on the image, which has not been marked at all on the segmentation map. We haven't had a chance to look into why that's the case, but you know, it reduced some people's confidence in the system. So the segmentation maps were generally valued. The suggested diagnoses were accepted by many, not all. It sort of depended on the prior attitudes to AI, but the management suggestions were mostly dismissed as being for some other context. They didn't reflect local practices, the local context within which those individual optometrists were working. So, you know, that's some examples of AI used in a very particular healthcare context. We've done studies in other contexts that kind of reinforce many of these findings too. So, kind of coming to a close, looking to the future, you know, we need to develop reliable, usable, effective, interactive AI systems. But in order to do that, we need to think about what data is measured, whether it's the right data, how that is analysed, what confidence, how algorithms are trained, what confidence we can have in those algorithms, and then how information is presented back to people for them to interpret that information. But we also need to account for how people work, what values people have in their professional expertise, in the risks of relying on technology to help them make decisions, in their priorities, in developing technologies that both work and that matter. So the diagram at the bottom is the idea of, you know, we need to measure it, we need to analyze data, and then we need to present it back to people. So in summary, you know, we're seeing huge amounts of innovation in digital health technologies. Some of it will be lasting, some of it will have a very positive impact. Quite a lot of it will suffer the valley of death. So health technologies can be transformative, but perhaps inevitably, I would argue that design needs to be user-centered. It needs to be inclusive of both professionals and patients with different levels of health and digital literacy, particularly on the patient side. Patients are very diverse. Care delivery needs to be user-centered. Technology design and care design need to be aligned. You can't just introduce a technology that forces people to work in very different ways from the way they've evolved over decades or centuries in terms of their work. And we need to be respectful of patient safety and data privacy. Because ultimately, healthcare is about care. It's about dealing with very complex systems, both the complexities of healthcare delivery, but also the complexities of individuals' health. And I think we can do this better. I'd like to think we can anyway. So I will leave you with some questions that perhaps we can discuss after the talk, you know, about why is it so hard to do better? And what are the different motivations for companies, developers, healthcare organizations, individuals, etc., to actually work effectively together? So I'd like to thank my team, particularly in this case, Josie, who's done a lot of the studies I've reported today, my various collaborators, study participants, without whom none of this would be possible, funders, again, without whom it wouldn't be possible, for providing me with opportunities, insight, creativity, and mostly making my work fun and engaging.